turn it over to you, and we'll begin.
Sounds great. Thanks, everybody. So our objectives today are, let's see, do I have control over the?
Yeah. Yep, you should have control now.
Okay. We're going to look at the basic concepts of medication management. We're going to look at what the research shows in terms of what the standards of care are for medication management. We're going to look at some of the highlights of the commonly used antidepressants. I've got some of the new ones in there also. And this can really help guide in terms of side effects and answering questions about medication choice, how to manage some of the more common side effects of antidepressants, and then thinking about interactions with other medications or even medical problems as well. So let's start with the basic concepts of medication management. And I always like to start with the question, do antidepressants work? Because a lot of our patients are, believe that maybe the medications don't work, and they're, kind of tolerating all of these side effects without even knowing if there's a known benefit to all of this. So there was a recent systematic review and meta-analysis that came out in The Lancet, and what they found, looking at over 100,000 participants, the vast majority of trials, these are funded by pharmaceutical industry, no surprise, because they want to show that their medication works. So take that as you will. It doesn't mean we can't, trust the data, but it could, just something to keep in mind. What they also found was that there's novelty bias. So that means new medications, medications they haven't tried before, and newer ones on the market, those tended to be reported as being more effective than the old tried and true ones like Prozac and Paxil. And then what they did find was overall, they felt comfortable saying that antidepressants, do show a benefit for major depressive disorder, and really in the first 2 months of treatment. Beyond that, data was a little unclear. And that antidepressants are more effective than placebo. So, a lot of people think that they are just about the same as placebo, but this study did show that they could be considered more effective than placebo. And that's something important to let our patients know about. And then the STAR-D trial, this was sequence treatment alternatives to relieve depression. This was a big study done in 2007, 2008, funded by the National Institute of Health. And so this was not funded by a pharmaceutical company. And so, of course, we felt more comfortable with the results of this study. And overall, what they found, I'm not going to get into detail just because of time, but what they found was after, the initial trial treatment, so that is starting a medication, and about a third of people will reach remission. That means complete resolution of depressive symptoms. Then on the second trial, either switching to a different antidepressant or switching or adding a medication to augment the effects of that antidepressant, about 30% of people, 20 to 30% of people did have resolution of their symptoms. However, once you get after the second medication adjustment, chances of remission start to decline. And this is probably a lot of the patients that you're seeing who have, quote unquote, resistant depression. I've tried a bunch of medications, nothing's worked. And we see that research shows that, if they haven't responded to the first couple trials, it's less likely that they'll respond. But of course, we need to keep going because we do see people do start to have, some people do have resolution of symptoms. And then another big takeaway that the research shows that it's unclear if switching medications across tapering, just tapering off the medication and starting a new one, or augmenting it like adding Abilify or Wellbutrin, it's unclear if one is better than the other. So it's really up to, a number of different factors, and hopefully we can kind of get into that a little bit after the presentation with questions. But you look at how the patient's doing on the existing medication, and you look at other factors, and that can kind of help direct whether you should augment or switch. But there's really no definite choice, at least based on research. So when should you consider medications for your patient? I mean, chances are they're going to be on medications already, but maybe they've taken a hiatus from medications and they're not sure if they need to get back on them. Or a lot of people say, I don't think they're working, I'd like to get off my medications. So as a guide, if their PHQ-9 is greater than 9, so 10 or higher, you want to think about treatment with medications, and that's because the research on PHQ-9 shows that people who have a score of 10 or higher are pretty consistently have major depressive disorder. And then if they're having any thoughts of self-harm or suicide, because we really want to reduce that risk, if they have any impaired functioning, relationships are impaired. A lot of people get divorced during major depressive episodes, or start to develop some scars in their relationships, lose friends, are not as present in their children's lives as they like to be, or they're failing out of school, they lose a job, or they're on probation because they kind of can't get it together because of the depression. We really want to help people remain functional in their lives. And I would also add, if they don't feel like they're living, so if they don't feel like they're living life to the fullest, and they're not able to really enjoy the things that they're doing or look forward to things, that's really an issue of quality of life. We want to help people have the best quality of life they can, because they're really aiming for overall wellness for people. And then if they have a history of a major depressive episode, even if they just have one episode, if they have a history of self-harm, if they have a history of a suicide attempt, or a history of hospitalization, then you want to think about prescribing a medication. And why is that? That's because, one, we want to reduce, so this is a little bit more in the preventive role. We really want to prevent and reduce the risk of course, self-harm or suicide and hospitalization, because now we know how severe their depression can get. The other issue is, once you have a major depressive episode, your chances are increased for having another one. And the more episodes you have, the higher risk you have of having another episode. So if we can just stop, the repetition of major depressive episodes, that can help and improve their course of depression as well. Oops. And then if their therapy and lifestyle changes are not helpful. So for example, they're in therapy, they're doing an hour a week, they've been doing it, for several months, and they're building some coping skills, but they just don't find that their functioning in life is improving, or they're doing yoga, they're exercising, they're taking up meditation, but they're still just not functioning. And then if they have a co-occurring substance use, so if they're drinking a lot, or recovering alcoholic, or they've relapsed, or chronic marijuana user, those are pretty common in my practice, I do prescribe medications for them, because I think there's more harm, and that research actually shows, before we used to think, well, people have to be completely sober before we can prescribe medications. However, research has shown, and the more current practice is, that people do better if you can start some treatment for their depression, because often, as you know, we do see that a lot of the underlying cause of substance use is untreated depression and anxiety. And then in terms of the interaction of alcohol and drugs, you talk to your patients about the risks. There's no absolute contraindication on, with most of the antidepressants. You might want to try an SSRI or SNRI. This is really when you want to consult the psychiatrist before making a decision like this. For chronic marijuana use, I haven't really seen any severe interactions except maybe sedation. So again, that's really when this is when you really want to involve the psychiatrist in the decision making. But this is just up here to really kind of drive home the point that we don't have to wait till they're sober, that when they're using, that is a time to really consider medications. So how do we choose one? Well, I usually ask what's worked in the past for you. Some people have tried medications in high school, or after they had their first child in their 20s, they did very well on it, and then they didn't need to be on medications for a while. You might think about restarting that medication, even if it was, Prozac. And of course, there's all these new antidepressants out there, but if it's worked before, chances are it'll work again. What hasn't worked is there a certain class of medications that they just haven't tolerated, or they just didn't do well on. You might want to avoid that class entirely. Genetically, people can have similar experiences and responses to medications, especially with first-degree family members. So I ask about family members. What are they taking? What was their response to the medication? What did they do well on? What didn't they do well on? If they have any current medical illnesses, for example, If somebody's got liver disease, you're not going to want to prescribe Cymbalta. So that's just an example of, getting their, you'll have their medical history, and you'll want to look at it and make some decisions based on that. And then of course side effects. If you have a morbidly obese patient, for example, you're not going to want to prescribe a medication that's going to cause a lot of weight gain, like mirtazapine, Remeron. You might want to go for one that's less likely. If they have hypertension, you don't want to prescribe Effexor or Pristiq or Cymbalta, because those are more likely to increase blood pressure. Sedation, you might want to stay away from Paxil, because that's one that makes people feel really tired. And then you want to look at dosing as well, and thinking about how you can manage the side effects with dosing, or do you need to just change the medication? Looking at their age and the side effects. If you have somebody who's older and more frail, you want to avoid medications that can cause dizziness, which pretty much are all of them, but more sedation, for example, might not be a good option. Cost, unfortunately, is a big issue. The newer medications, Trintellix, Fibrid, Fadzima, these ones, even Pristiq, are hard to get approved. And so though maybe their genetic testing has recommended them, they've heard of them, they want to try them, it can be a limiting factor. And then you want to think about drug interactions. So if they're already on a medication, that could interact with one of the antidepressants. For example, if they're taking Seroquel for sleep, that's a medication that can affect a QTC prolongation. You want to avoid Celexa or Lexapro, because those can exacerbate that interaction. And then I think genetic testing can be useful for a number of people. It's not rock solid, so I don't think everybody has to have it, but I think it has some useful information. So we use GeneSight, and it's just one of the options. In GeneSight, they compare 12 genes from a buccal swab that they'll take in the office, and they compare the patient's 12 genes to about 55 psychiatric medications, the most commonly used ones. And they do it in all classes: mood stabilizers, antidepressants, anxiolytics, antipsychotics, ADHD medications, so stimulants. And then they list in 3 different categories. They'll be green, yellow, or red. Green being the medications are most likely to tolerate well and have a chance of having an improvement in symptoms, to red, which is possible or known interactions with their genetic makeup and medications that they might not tolerate well or should not try at all. And they've done some research, and they have found with GeneSight that it can improve remission rates. That means complete resolution of depression by 50% for people with major depression, if you choose a medication that's recommended by the genetic testing, so one in the green zone. It can also improve response rates, so an improvement in symptoms or a decrease in their PHQ-9 by 30% for people with major depressive disorder. So there is some evidence that it can be useful, and that might be a way of directing medication choice, especially for people who have had very severe side effects. They're very afraid of the side effects of medications. Medications just haven't gone well for them. I think it's a great option for those folks especially, and I will recommend it for them. It also, genetic testing gives you some insight into how they metabolize medications and what their risk is for some of the more serious side effects like Stevens-Johnson syndrome and some other rashes. So for example, Lamictal can cause Stevens-Johnson syndrome. So if you have someone with an increased risk, you're going to want to avoid that medication, and that's very useful information to have. So let's move into some of the evidence-based management. So I'd like to start with treatment goals. So what really is our goal? Well, response is good. That's considered a 50% decrease in symptoms, or you can go by 50% decrease in their PHQ-9 score. Or remission. That is 6 months of no symptoms of depression, or a PHQ-9 score of less than 5. We consider no depression. And then when we talk about prevention, we want to continue the medication bare minimum 6 months, but ideally 12 months after symptoms have completely resolved. So if they've been taking an antidepressant and it takes about a couple months to get to the right dose, and they come back and see you and they say, my depression's completely gone, their PHQ-9 is 3. Then starting from that date, I would recommend they stay on the medication, and I tell them ideally a year. but we can start with 6 months and see how you feel. And then I'll often check in with them. Do you have any major stressors coming up? Any big life changes that might make them say, oh yeah, I think I want to keep it longer than 6 months. But that prevents the recurrence of a major depressive episode. And then maintenance. If people have already had major depressive episodes off medications, so they say, I took medications, I've been off for 5 years, didn't go well off the medications, I had a couple deep depressions, or they're moving, they have enough, they're in the middle of a divorce, things like that, you might want to encourage that they continue the medication indefinitely for a period. And then you can reassess. Course of treatment, so we always talk about side effects from the day you start the medication can last, mostly about 1 to 2 weeks, but I have people who still are, dealing with side effects into 3 and 4 weeks. And then therapeutic effects really start, we say we need about 4 to 6 weeks, but, in the first week, people feel like it's working, it's probably placebo, or it might be the side effects of the medication, like a histaminic medication might be making them feel more drowsy, they feel more relaxed, they're sleeping better, maybe that's why they're feeling better. But I see the edge can really be taken off of symptoms for people in 2 weeks. And I find that it's kind of encouraging when you tell people it's going to take about 4 to 6 weeks to work, but in some people, the edge is taken off in 2 weeks. So be on the lookout in a couple weeks. So they feel like it's not going to take forever. And that is the truth, that I have seen that for some people. But you want to treat at least for 8 weeks. In the STAR-D trial that we looked at, sponsored by the NIH, they really saw improvement around the 6th or 7th week for folks. And then, like we talked about, we want to treat for 6 to 12 months after remission. So that's complete resolution of symptoms. Okay. There we go. So let's talk about dosing. For our elderly patients, 65 and older, you want to start really low. So I try to start at half the usual starting dose. So what does that mean? For Lexapro, usually maybe you start at 5 milligrams or 10 milligrams. I start at 2.5. And I have them do that for a couple weeks, and I just keep it there, and then I check in with them and just see how it's going. There's no reason to push it too fast, too soon, because the key is you want people to be able to tolerate the medication. And if they're not tolerating it, or they're having severe side effects at lower doses, they are likely getting the same therapeutic effect as somebody taking double the dose, if they're feeling the strong side effects. So there's there's nothing that says you have to be at 10 milligrams of Lexapro to feel an effect. I have people taking 2.5 who actually are doing well because they are very sensitive to the medication. They're slow metabolizers. Genetic testing can be used as a guide. There are little footnotes that tell you, patient may need a lower dose of the medication. So certainly you want to start lower for those folks. But you don't want to stay too low. You do want to adjust it as tolerated. So if they're tolerating it fine, despite genetic testing saying that they might need a lower dose, or despite their older age, but their symptoms still aren't resolved, you do want to push the dose. So we don't want to undertreat people, but we want to really shoot for tolerability first. Because it's better to start low and have them tolerate the medication, then you can adjust it more easily as you get up higher on the dose. If you start a medication, someone has a partial response to it, you want to think about increasing the dose every 4 to 6 weeks. That's not a hard and fast rule. Sometimes I increase it in 2 weeks. Kind of depends on the severity of the illness, a history of if they've needed higher doses of medications before, they generally don't have side effects and tolerate medications well. If someone's done well at 200 milligrams of Zoloft, I wouldn't start them at 25 and do that for 4 to 6 weeks. I would crank it up sooner, especially if I know that they've tolerated it well. But in general, if it's someone you don't know very well how they've done on medications, it's a new medication for them, you really do need 4 to 6 weeks to really see if the medication at that dose is working. Once you get to the maximum dose, then you can think about, if they haven't had a good response, switch or augment with by adding another medication. So I usually try to max out the current medication because we always want to reduce polypharmacy. You know, our folks have a lot of medications, a lot of medical medications. So if we can get away with one medication, ideally that's what we want to do. So augmentation versus switching, like we talked about before, not clear if one is better than the other. You want to augment, I'm just going to kind of briefly go through some of the common augmentation techniques. I usually start with Abilify. Why? FDA approved for major depression. It worked quite well for a lot of people, less likely to cause weight gain. No QTC prolongation, so it's one less thing you have to worry about in terms of side effects. It's not overly sedating. So it's usually the one I start with. Seroquel also approved for depression, but can cause a lot of weight gain and can be very sedating. It's a good option if somebody's having a lot of trouble sleeping. Risperdal, this is one that I still have people who have trouble getting Abilify or Seroquel approved, believe it or not, by their insurance. Risperdal is one that they readily will approve. They use this a lot inpatient and partial hospital. I don't prescribe it as much. I'll usually do Abilify or Seroquel. Risperdal can act like some of the older antipsychotics where you have greater risk of abnormal muscle movements with it that can become permanent, had a lot of sedation and weight gain. And I have people, because of the increased production of prolactin because of the dopamine blockade, Risperdal can cause lactation and enlarged breasts for men and women. Zyprexa, also a lot of weight gain and a lot of sedation. Another option for somebody who's having trouble sleeping. And I'm also listing this in the order that I would actually try the medications. Lithium, underused medication for major depression. Even though it is a gold standard for bipolar, it works quite well in major depression when you add it to an antidepressant. It doesn't work well alone, but it can augment an antidepressant, especially if somebody has chronic suicidal thoughts. They do quite well. It really starts to resolve those suicidal thoughts. There are some contraindications to lithium. So people have renal disease, cardiac dysfunction, prone to dehydration. You want to be careful with lithium. But otherwise, for the majority of people, they can, there aren't any contraindications for it. And then thyroid hormone, T3, most of the research is on T3. Adding that to an antidepressant definitely can boost energy, motivation, and boost mood. I've had some people do well on it, but you have to watch that the T3 doesn't then make them hyperthyroid. And of course, if they already have a history of hypo or hyperthyroid, you don't want to choose T3. And then Wellbutrin, less kind of robust response as an augmentation, but what's nice about it is you don't have to check blood levels with Abilify, Seroquel, Risperdal, Zyprexa, and lithium, and T3. You do have to check, their blood work. With Wellbutrin, you don't, but it's less robust of a response. And then tricyclic antidepressants like Elavil or nortriptyline. Some people might already be on these medications for sleep or pain. You do need to watch out for an interaction between the tricyclics and other antidepressants, because other antidepressants can lower the metabolism of these tricyclic antidepressants, so you're effectively getting a higher serum concentration. And so you can check an Elavil, an amitriptyline, nortriptyline blood level just to make sure that that hasn't gotten too high. And let me go back. And then Buspar, not much evidence for Buspar for depression, but adding it for general anxiety disorder does seem to help. And then, so now let's go through the commonly used antidepressants. I'm not going to go into too much detail. I believe you have a copy of these, so it's better used as a reference. But I just want to go through some of the highlights. The SSRI, selective serotonin reuptake inhibitors, they block the reuptake of serotonin. So they're effectively blocking the breakdown of serotonin in the brain. So they effectively have higher levels of serotonin. It takes about 4 to 6 weeks for that to happen, and that's why the delay in the therapeutic effect. So these are the common medications. They're more commonly used than Elavil, amitriptyline, nortriptyline, and the older antidepressants because they're safer in overdose. They don't cause the same cardiotoxicity. and they're better tolerated in terms of side effects. In general, less weight gain and less sedation than the older antidepressants. Prozac, fluoxetine is a good one for people who have trouble with medication withdrawal. Serotonin withdrawal is a 4 to 5 day half-life. It hangs around in the system a long time. That means it takes about 5 days for the medication to get to half its concentration. So it's around for a bit. Want to be careful with citalopram and escitalopram, Celexa and Lexapro. They have black box warnings for the maximum dose because of increased QTC prolongation. And you also want to be careful about what other medications they're taking that can also increase risk for QTC prolongation. You want to limit the dose of these medications for patients greater than 60. You can have hyponatremia in elderly folks with SSRIs, so you may be wanting to check a basic metabolic panel for them. You want to use a lower dose of these medications if they have any liver dysfunction, but they're fine in renal dysfunction and dialysis. The SNRIs, they have dual mechanism where they block the reuptake of serotonin and norepinephrine. This is your Effexor, Pristiq, Cymbalta, and one of the newer ones, Fetzima. Withdrawal symptoms are quite pronounced with Effexor, venlafaxine, 5 hours versus 5 days with Prozac. So people do have some trouble getting off this medication. You want to avoid Cymbalta in liver disease. All of these medications can increase blood pressure, so you want to monitor their blood pressure and pulse each visit. And they may be better for people who have chronic neuropathic or musculoskeletal pain, especially Cymbalta. You want to use lower doses in hepatic and renal impairment. Norepinephrine and dopamine reuptake inhibitors, so just a slightly different mechanism of action. Bupropion or Wellbutrin is the most common, less sexual side effects and less weight gain. So this can be very enticing. It does not treat anxiety. So if somebody has really bad anxiety and depression, Wellbutrin's may not be the best choice, because you want to try to treat both with one medication if you can. Increased risk for seizures. So if someone's got bulimia, anorexia, prior seizures, head trauma, tumors, drinking alcohol, using stimulants, you want to avoid it. Can be helpful in smoking cessation. It's marketed as Zyban for that. So, you know, it's always nice to try to treat two things or multiple things with one medication. If somebody, you know, is concerned about weight gain, they're feeling tired, and they're smoking, no anxiety, Wellbutrin could be, you know, the obvious choice. You want to watch caffeine intake. It can precipitate palpitations with Wellbutrin, and it can cause insomnia if it's taken too late in the day. So you want to tell them to take it earlier than about 4 p.m. And you want to give 8 hours between doses if you give the SR version, which is twice a day. Tricyclics, these are your older SNRIs, so the older version of the Effexors and Cymbaltas. And these are used less so for straight antidepressant and anti-anxiety, and more so for pain and sleep. Higher overdose risk due to cardiotoxicity, but they're good, you know, for chronic pain. They can help with IBS, insomnia. But dizziness and these anticholinergic effects with like blurred vision, constipation, dry mouth, make them less popular. And like we talked about, can interact with the SSRIs. MAOIs, I'm not really going to talk about these. We don't really prescribe them as much. If you do feel like you're all out of choices of medications, you've gone through every single thing, your patients asked about an MAOI or they're on one, these are the older ones, older than the TCAs. Selegiline is often recommended on genetic testing as a transdermal patch. You have to have a tyramine low diet, and they have to wash out if you're using other antidepressants. So I would consult the psychiatrist if you're going to use one of those. And then trazodone, it's a mixed serotonergic medication. We use it mostly for sleep, though it is an antidepressant. And excuse me, a risk for priapism, that's prolonged erection. It does happen. So that's something to discuss with your male patients. Of course, sedation, dizziness, and morning grogginess. Vibrid, this is newer on the market, so less likely to be covered and expensive. This is a newer mechanism of action, partial agonist of serotonin and also blocking reuptake. Does not need to be adjusted in kidney or renal dysfunction. And then a slightly different mechanism of action. So we have alpha to adrenergic antagonists and serotonergic function. So Remeron or mirtazapine is one of the more common ones. So it increases serotonin and norepinephrine transmission, and that is independent of reuptake. So it is slightly different than some of the other antidepressants. The lower doses, about 7.5, that's really used for insomnia, because at these lower doses you have more histamine action. Once you start getting to higher doses, 15 milligrams or higher, it's less histaminergic and more serotonergic and noradrenergic. So more serotonin, more epinephrine. And so then we're getting into now the antidepressant doses. Good for patients that need to gain weight. You tend to have more weight gain because, again, of the histamine effect at the lower doses. So, do we have patients who need to gain weight? Sometimes, yeah, we do. And it may also help reduce nausea. So if you have somebody who's got chronic nausea and they're not eating and they're losing weight, this is a good medication for that. You do need to lower the dose in kidney and liver dysfunction. Multimodal, Trintellix, this is new on the market. It's expensive, but it has multiple mechanisms of action. We're tapping into serotonin, norepinephrine, dopamine, glutamate, all different types of neurotransmitters. And so maybe this is, because it's a novel medication, that for people who just have not responded to the traditional antidepressants, perhaps this novel approach could be helpful. No dose adjustments needed. They tried to get an FDA approval to say, to be able to market it as helping with cognitive impairment. They did not get that. But I still do use it for patients who are having some short-term memory, that feel like they're not thinking clearly, and I've seen okay results in terms of that. I think Trintellix, in my experience, these newer antidepressants seem to work just about the same as the other ones. So managing side effects of antidepressants, this is probably, where you're going to be mostly involved, because you're going to be first line, and this is what mostly we talk about in our appointments, is that tolerability. And so that's why I say start low and go slow. You do go, but make sure they can tolerate the medication, because if they can't, that reduces their chances of them wanting to try another one and being able to benefit from the effects of the medications. So first, short term, usually first, second week of trying it, common, I tell them headache, stomach ache, nausea, dizziness, dry mouth, diarrhea, constipation, and then I say, just like on those TV commercials, any type of, symptom is possible with these. But those should resolve in the first week or two as your body gets used to the medication. Longer term and dose-dependent side effects, sexual side effects, lack of orgasm, lack of interest in sex, delayed orgasm or can't have one, dry mouth, constipation or diarrhea, night sweats or sweating, and weight gain. Suicidality with antidepressants. Most of our patients are above the age of 24. And if you're above the age of 24, antidepressants show that they actually can reduce suicidality. But for our patients 24 and younger, there is a slight increase in risk of suicidality when starting an antidepressant and when adjusting the dose. Why is that? There might be something in people's brains where these medications trigger suicidality. It might be undiagnosed bipolar that's getting triggered. It's creating some activation of hypomania, mania, that's resulting in suicide. And so I see that as a warning sign, and I do a closer bipolar screen if people say I became suicidal on that medication. So this is something to talk to our patients who are 24 and younger, that if you start having suicidal thoughts, and they often start, they're ego dystonic. People say, I'm not feeling depressed, but for some reason I can't stop thinking about suicide. So you want to let them know, stop the medication, get urgent help, make sure that they're safe. And then weight gain. This study just came out in the British Medical Journal this year about weight gain and antidepressants. We know they cause weight gain, and this seems a little bit busy, but in general, there's about a 20% increased chance of gaining 5% or more of your body weight in the first year of trying a medication. So 20% chance of gaining weight, 5% or greater in the first year you try an antidepressant. That risk goes up to almost 50% after 2 years. So the greatest weight gain with an antidepressant is in the second and third year of treatment. So when people say, oh, I've been gaining weight with Zoloft, but it started, this year, I've been on it for 2 years. This was news to me. I would say, oh, well, it's probably not the medication because that would have happened sooner. Well, I'm going to start changing my response since I read this study that we have to think about long-term effects for our folks. And then this is just based on percentage of prescriptions. So these are the more commonly prescribed, less commonly prescribed. But looking at Remeron or mirtazapine, because of the histaminergic effects, especially at lower doses, highest risk of weight gain. And then Cymbalta's up there, Lexapro, Trazodone, less so Paxil or paroxetine. So, you can kind of use this maybe as a guide for patients, but I will say everybody is different. Some people will gain a ton of weight on Remeron, some people don't gain any weight, so it's case by case, and I always just trust my patient if they say they gained weight or they didn't. And then preventing and managing side effects, genetic testing can help quite a bit. Especially if someone's just having chronic problems with side effects, you've gone through several trials, they just can't tolerate anything, I would get the genetic testing, make sure it's affordable for them. Start at half the starting dose, divide doses. If they're feeling really, groggy the next morning, maybe they could take half the dose at dinner time, half the dose at bedtime to split it up a little bit. Or take it with meals if they're feeling nauseated, or switch it to morning or bedtime, depending on how it's making them feel. Avoid caffeine if they're feeling kind of too anxious on it or having palpitations, they feel like they're gaining weight or it's making them tired, or they're not sleeping well. Increasing exercise can help. Trying to continue the same dose until complete resolution of symptoms. So you tell them, start at 10 milligrams of Lexapro, start at 5 milligrams. I tell them, don't increase it to 10 until all of your side effects are gone. And if your side effects aren't gone by the time you see me, that's fine. Stay at 5 milligrams because the key is you can tolerate it. And then choose wisely. If they have a history of hypertension, you don't want to try Effexor probably shouldn't be your first choice. If they're obese, you want to stay away from Remeron. If they have high anxiety, you want to stay away from a medication that might exacerbate anxiety, like Prozac can do that sometimes at the beginning. If they're having insomnia, maybe Wellbutrin's not a good choice, especially if they're going to be taking it twice a day and closer to bedtime. And then there's the option also to treat the symptoms with another medication. For example, sexual side effects. For men and women, you can use Viagra and Cialis, augment with Buspar. There are some other options in terms of treating sexual side effects. And then this is a small slide, which is hard to read, but you do have it. And I think this is really great in terms of summarizing the side effects and handing it out to your patients. And they have really great, initial interventions for each of these symptoms, which, can reduce phone calls and stopping medications and, becoming discouraged on the medication. I often get a question about missed doses. And what I say is if you've missed 3 or more days of the medication, certainly you're going to have serotonin, withdrawal. You're probably not getting the therapeutic effect anymore. And we may need to restart the medication at the starting dose to decrease risk of side effects. So it's really important for taking the medications consistently. And withdrawal can happen if you even miss it once. And people will tell you that. They feel more depressed, they're crying, they're more anxious, insomnia. Taking the medication at the next scheduled time. So if you miss it, don't double up. Just wait until the next time you're supposed to take it and take it then. Stopping medications, we need to taper each one of these antidepressants. Even Prozac, I do taper Prozac even though it lasts a long time. Or people can have, suicidality, electrical zaps, especially with the Effexor when they're turning their head or blinking their eyes, headaches, dizziness, all types of symptoms. The longer they've been on the medication, the higher the dose, the slower you want to taper it off. And the shorter the half-life, the worse the withdrawal. So for example, Effexor, you want to go a lot slower. So for example, if someone's been taking Lexapro 10 milligrams, they've been doing it for 6 months, I'll have them go down week by week, down by 2.5, and then go 2.5 every other day. And then by the 5th week, I'll have them stop. And then what I'll say is, by the end of the first week, if you're still feeling like a little bit jittery or you don't feel ready to go down to 5, do another week of 7.5, then go down to 5. There's no rush to get off of it. The key is you want to reduce the symptoms that they're having. If you're cross-tapering, if you're getting off Lexapro and not replacing it with the serotonergic medication, then you want to go slower. But if you're getting off Lexapro and replacing with Zoloft, for example, you don't need to do such a slow taper. Then you do a cross-taper. And you can work with your provider or the psychiatrist on how to do the cross-taper. And then I just want to end with some key drug-drug interactions. The main thing is use Lexicomp. It's in UpToDate, and what I do is I just put all the medications a person's taking in there, and I hit the button interactions, and I see, and it gives me all the alerts because it's hard to keep all of that in your head. We use Epic now at Pine Rest, and so Epic has a built-in drug interaction check. So check with your EMRs that you're using and see if there is a built-in interaction check. That is hugely helpful, and you should be doing it for everybody, especially when you want to start a new medication. But in general, some of the things we think about are serotonin syndrome when you're combining serotonergic medications. It's more common when multiple agents are combined versus if they're just taking one serotonergic medication. It can be dose dependent, higher risk at higher dose. You can have fever, abnormal muscle movements, rigidity, confusion. It's relatively uncommon, but it's something that we need to consider, and they do need to get medical care. They need to stop the medication right away, go to an emergency room, get fluids so that they don't get dehydrated. NSAIDs, so these are your ibuprofens, naproxen, those themselves increase GI bleeding, and antidepressants can also worsen that bleeding. So in combination, you want to be careful. If people are using a lot of ibuprofen, I tell them to use Tylenol when they're on an antidepressant. Alcohol and drugs, you want to be aware of central nervous system depression, respiratory depression, MAOIs, hypertensive crisis, few people are on. We talked about tricyclic antidepressants, the serum concentration going higher. Tramadol for pain can lower seizure threshold, and antidepressants can also all lower seizure threshold. So in combination with tramadol can increase risk for seizure. Certain antipsychotics like Seroquel or Geodon especially can increase QTC prolongation. So if you're combining, you want to avoid combining, for example, Geodon with Celexa at any dose, really, because they are all QTC prolonging. You want to check an EKG. There are other risk factors, being female, alcohol, other medical medications as well. Most interactions involve the P450 inhibition through liver metabolism. And so if a patient's taking medications known to interact with an antidepressant, for example, if they're on a tricyclic antidepressant, you want to start low, go slow, monitor for side effects and interactions. They're feeling too tired or too sleepy, confused, dizzy. And then for tricyclics, you can check a blood level, and you do a trough. Check it 12 hours after the last dose of the tricyclic antidepressant. And then there's a list of drugs that can also cause depression. So, oh, sorry about that. I did not mean to do that. So it's good to just take a look at these and, be thinking about other causes of depression, interactions with these medications, and how, you're prescribing some of them. For example, benzodiazepines, clonidine beta blockers could be worsening a patient's depression as well. And that's it.
All right. Thank you very much, Dr. Agarwal. I'm going to unmute the line, so folks make sure you don't have your phone on hold, and/or if you've got other conversations going on, if you could just mute your line on your end, that would be great. And we'll open it up for conversation discussion. So, okay, everyone should be able to join in, and if you have questions, feel free to ask them, or if you're not comfortable asking them to the group out loud, you can certainly type in your questions on the chat box.
Okay, I see a question that just popped up. It says, how long would it take if you were on a drug like Seroquel and had to switch due to weight gain? Length from stopping one and starting another. Great question. Somewhat unsatisfying answer is it can vary, but let's take an example. So somebody's taking Seroquel, they're doing 50 milligrams at bedtime, but they've gained 10 pounds since they started it, and they were sleeping well, their depression was better, but now they're gaining weight and they need something else. So you can think about, so what I do, I would look at what other medications that they've taken and tried. One clue, let's say, for example, this person's depression did get better on the Seroquel, but it's just that they're gaining weight. And that's unfortunate. So some things we can do are you could decrease the dose and see if that has less weight gain associated with it. And are they still getting some of that antidepressant effect? Another thing would be, say like you've decided that we need to switch the dose, or the patient saying, I've gotten too much weight gain, I want to get off the medication. Okay, so we know that the antipsychotic class, atypical antipsychotic class, has worked for their depression. So maybe we want to think about sticking to this class. And I would think of something like Abilify or Geodon, which have less risk of weight gain. And probably Abilify, for example. So Seroquel, if they're taking 50 milligrams, what I would do is I would say for 1 week, go to 25 milligrams of Seroquel and take, 5 milligrams of Abilify, and do that for the first week. And then the second week, I would just have them off the Seroquel, and then I'd have them increase Abilify to 10 milligrams, and then just kind of see how they do. And you might want to warn them that Abilify is not going to have the same effect on their sleep. And so you want to think about what else you can do in terms of sleep for them. Maybe the Abilify makes them a little bit tired, and that can help. Or, if they're already taking a benzodiazepine, for example, if they're taking clonazepam, you can say, if you're taking it twice a day, save the second dose a little bit before bedtime to see if that helps. Or you might need to add a sleeping medication because the Abilify is not going to have the same sedating effect of Seroquel. But when I'm cross-tapering, I do get them off fairly quickly, unless they have a history of I've tried to get off Seroquel and it didn't go well. Then I might go even slower. Then I might say do 2 weeks at 25 milligrams and 2 weeks at 5 milligrams of the Abilify. Then, then stop. Or then do 2 weeks at 12.5 and 10 of Abilify, and then stop. So you kind of look at their past history, how they've done getting off medications, what their sense of urgency is, and what your sense of urgency is to get them off. And then what I do is I write out a taper, and I say, you can go faster or slower, and you could repeat the first week or the first step as long as you need to before you feel ready to go to the next step. And then, of course, there's sometimes when you want to just get off, like if they're QTC, they're having palpitations, they're having dizziness, there's concern that they have an abnormal EKG, stop it right away, and you just kind of deal with the consequences. But if you're cross tapering, I can switch it within a week. If you're getting off Seroquel, like they've done well, and you're just getting off completely, I would go slower. Then I would do, a couple weeks at 25, couple weeks at 12.5. Maybe a week at 12.5 every other night, and then stop it. Okay, next question. I have many geriatric patients that have been on Ativan for decades who are not being weaned off by PCPs. I've heard that can actually be contraindicated for long-term users. Is that accurate? If not, is there a good medication to use as a cross taper with this population? Okay, yeah, tough question. I mean, tough situation. If it kind of depends. I mean, if they've been doing well on Ativan, it's keeping them functional, it's helping them sleep and stay well rested, it's managing their anxiety, it allows them to be social. They haven't needed higher and higher doses. They've, maybe been on the same dose for years. They're not having extra falls or dizziness because of it, and they haven't misused it. I don't see a great urgency to get them off. It can be very destabilizing when you taper off benzodiazepines. That doesn't mean don't do it, but you just have to know it's a very, very destabilizing period for people. And so what's the reason for destabilizing them? Is it just because you just think people shouldn't be on a benzo, or is it because you believe this is causing some problems for this patient? And they're not doing well because of it, and you feel the benefit outweighs the risks of getting them off of it. So there's no hard and fast rule. I think in the geriatric population, we have to be careful about creating problems. So are we creating falls? Are we creating ataxia? Are we creating confusion? In that, we have to just evaluate for that. But if you have a geriatric patient who's doing fine, I wouldn't necessarily destabilize them by taking off the Ativan, unless they're needing higher and higher doses or there's some concern for the use. If there's someone who we feel Ativan is just causing dizziness and a lot of problems for them, they're not doing well on it, they're very groggy in the morning, if they take it at night, you want to get off, good medication to cross taper. It kind of depends what the issue with Ativan is. Is it lasting too long? In that case, I might give them Xanax that would be shorter acting if they're using it for bedtime, for example, or panic attacks. So it's not lasting so long in their system, so they're not feeling so sedated and tired. But if they just don't do well on benzodiazepines, or there's maybe some concern about addiction, gabapentin can be a useful medication, especially I have a lot of people in recovery for alcohol, and gabapentin tends to work well, probably because of the action on GABA, and that might be a good one to try to cross taper them to. What you have to do is you have to prepare them and say, this is not going to feel like your Xanax. This is not going to feel like your Ativan. It doesn't kick in as potently, but it does allow for some relaxation. So just preparing them that it's going to work differently. Any thoughts on over-the-counter supplements that are targeted for depression and or anxiety, such as 5-HTP, SAMe, or adrenal cortex? Good question. I'm going to refrain from making any recommendations on those medications, on those supplements. In general, if I have people asking me about them, I will say, based on the research that's out there, they're not as effective as prescription medications. So if you have a moderate to severe depression or anxiety, I would recommend medications. However, if it's somebody who feels like they're actually helping and they're not causing any problems, they're not having any side effects, I would say continue them. But then you can't prescribe antidepressants along with these medications. You have to worry about interactions. Adrenal cortex, I don't know, I'm not familiar with that one. But especially St. John's wort, I mean, you have to be really concerned about prescribing an antidepressant, so you have to kind of ask them, what do you want to do? Do you want to treat this more naturally with supplements, or would you like to treat it with medications? But they will need to do one or the other, unless it's like fish oil or something like that. The medication Trintellix is becoming more and more popular for how it works. In short, can you explain your thoughts on it and its efficacy, side effects in comparison to the old faithfuls? Yeah, it is becoming more popular because it has a novel mechanism of action, and it's multimodal, and this is kind of the new way that antidepressants are going. Of course, I'm only one provider, but based on my experience, I don't see that it's phenomenal compared to any other antidepressants. And I'll tell you, I got a lot of people on Prozac, Zoloft. I use those a lot, and people do well on them. They're tried and true. There are no head-to-head studies that show that one is superior to the other. We know less about the newer antidepressants, especially in terms of side effects. I do have people who cannot tolerate these new medications. So I have had the same incident of side effects and wanting to switch off and it just not doing anything. I haven't seen any remarkable difference so far. That's with Trintellix, Fatsima, Vibrid. One thing I have noticed is that, and I think this goes back to that novelty bias that we talked about in that one study that looked at do antidepressants work. I think initially people like the idea of trying a medicine that's newer. One, it's probably recommended by genetic testing, and two, because it's new and what's new and shiny, you know, is very attractive, and well, if it's newer, it must be better. That has not been my experience. Is being weaned off Ativan contraindicated after long-term use? Not necessarily. There's no reason, you know, if somebody's doing poorly on the medication, it's not working, it's interacting with other medications, they're having terrible side effects with it, you don't feel like it's safe for them, they're misusing it, they're taking more than recommended, or they're just needing higher and higher doses. It's not contraindicated. What you might want to do first is transition them to a longer acting benzodiazepine like clonazepam or diazepam, Valium or Klonopin, because those, because they have a longer half-life, they can be easier to get off of in the long term. And what I would do is just transition them to the longer acting benzo, have them get used to that for a month or two, and then begin the taper off, depending on how much time you have. I mean, if they're having serious side effects, you're going to want to do it sooner. You know, you might transition to, you might just get off the Ativan directly. But there's no absolute contraindication. And I do get people off their benzodiazepines. You have to go real slow. Over the course of 2 or 3 months, that's what I do. I go very, very slowly. Any other questions? Or cases people have had that kind of had some questions about, or were treated differently than you thought maybe they should be, or issues that keep coming up for you? Is lithium more old school? I do not see it very often. It is old school. It's the gold standard, original gold standard for bipolar, found serendipitously to work for mood stabilization. It's dirt cheap, it's readily available, it's been around for years, and it works very well. So, you know, when we're talking about antidepressants, are there any head-to-head studies? I don't see one's better than the other, but if you ask me about mood stabilizers, lithium is dramatically better than others. You know, maybe a bit better than Depakote too, but Depakote's up there too. Lithium is really for bipolar 1 or 2. For bipolar 2, the less severe, we really kind of look at the data for bipolar 1 and we follow that. But I think we don't use lithium as often because the atypical antipsychotics are around and they somehow feel easier and safer and less scary to use. Lithium itself is not that scary if you just don't have any kidney contraindication or cardiac contraindications. You do have to check blood levels. It can affect your thyroid. People can become toxic on it, especially when it's humid and hot outside, if they're on thiazide diuretics. So there are some interactions. If you're checking the lithium level every time you increase the dose, you know, you want that level to be around 0.8 or 1 for therapeutics. You know, you check in with people more frequently and you ask them about tremor. A lot of people have kind of just a little fine tremor. That indicates to me the level is a little high for them, even if the blood test shows it's not. I go by symptoms, and then I lower the dose, and that's how you reduce toxicity with lithium. You can also give them the entire dose at once, the entire dose at bedtime. That reduces risk of renal impairment with the lithium. But it is very effective to add on for major depression and very effective in bipolar. Is it common to see trazodone and Seroquel prescribed together for bipolar? I do see that, but I would recommend one or the other. And I would recommend Seroquel over trazodone because say like this person's on Lamictal and Trileptal for their bipolar, and then they're taking trazodone and Seroquel. I would check in with them. Do they feel like one's working better than the other? If not, Seroquel's at least going to add some more mood stabilizing properties for bipolar. So you're getting an additional benefit. Trazodone's not really doing anything for the bipolar. But Seroquel is going to help you fall asleep, and it's going to add additional mood stability to help the lamictal and trileptal or whatever other mood stabilizer they're on work a bit better for mood. So I would opt for the Seroquel. I would try not to have 2 sedating medications together at the same time at bedtime. However, it's case by case. If this person says, I have to have both, I've been on this for 10 years, I can't sleep without these 2, then you want to just monitor. You're welcome.
And the discussion appeared to be about an additional payment for silence. Apparently on the audio, you can hear Mr. Trump saying that it should be done for meaning and not by cash. What his lawyer said to us, Rudy Giuliani, is that shows that.
And I would encourage people if you think about augmenting or your provider is augmenting an antidepressant, think about Abilify Seroquel first, and Wellbutrin later down the line, because you might get better effects with the Abilify and Seroquel. And Buspar, just really kind of reserve that as an add-on for generalized anxiety, because it doesn't really work that well as an add-on for depression. I don't know if that's what people are already doing, but most people have diabetes or hyperlipidemia, so you're already checking lipids, basic metabolic panel, A1C. Those are what you need to do. You need to check for Abilify or Seroquel. So if you're already kind of checking those labs, it's nothing additional that you need to do. Unfortunately, I see more and more patients with bipolar issues because psych is becoming so far, and patients can't find one. Absolutely. Bipolar presents in primary care clinics equally as much, and in some cases more so than in psychiatry clinics, if you can believe it. You guys are seeing more bipolar folks than I am, possibly. And I'll tell you, when I do collaborative care, a lot of your patients are more complicated than mine. I don't have as medically complicated patients, and with the same severity of bipolar. So becoming comfortable with bipolar is becoming just as important as becoming comfortable with major depression and being able to tell the difference. And then, so how do you know to try an antidepressant or a mood stabilizing medication? Starts to get a little tricky, and this is where working with the psychiatrist in terms of having an algorithm for bipolar screening is really important. Part of depression screening is bipolar screening. So I use an assessment form called the CIDI. It's available online. You can just Google CIDI bipolar screen. It has questions worded in a way that I think really does start to narrow it down to bipolar versus just more kind of general questions like the mood questionnaire, which can be kind of vague. And I ask, I would say go through that assessment, ask about postpartum depression. Women who have postpartum depression often have bipolar. Ask about suicide or getting kind of revved up, giddy, insomnia, agitation with antidepressants. That's also could be a sign of bipolar. Family history of bipolar. And so those can be some warning signs, and then doing that CIDI, which is basically going through the criteria for bipolar. If you have a suspicion, one of the nice things about augmenting with Abilify or Seroquel or Risperdal or Zyprexa is if they have bipolar and we kind of missed it or we're not sure, you're covering that treatment by using one of those antipsychotics, because those are mood stabilizing and they treat bipolar. So that's one of the other benefits over using Buspar or Wellbutrin or even T3 for treating depression. I have a lot of cases where I'm like, I don't know, this person has bipolar. I can't tell. I'm not sure. The way they're answering the questions, they might not be a great historian. They just kind of can't remember or some things are positive, some aren't, you know, I'll have a lower threshold to augment with Abilify or Seroquel or even lithium. Not necessarily Lamictal, but more so lithium in terms of mood stabilizers added to antidepressants. And that way you've covered them. So you're not really missing the bipolar. How often should the care manager check in and monitor a patient when newly started on medications? And what are the key questions or information they should consider assessing? Great question. When I first start a medication, I follow up with them in 2 weeks. So you might think about doing 2 weeks. And of course, each time you meet with them, you do want to check a PHQ-9. And then, you know, I would say 2 to 4 weeks, depending on how they're doing. If they come and they see you and they're having a lot of side effects, and, you know, then I might see them again in 2 weeks. Anytime you make a medication adjustment, you want to see them in 4 weeks. You know, at least 4 weeks, because you're going to need that much time to see a therapeutic effect. But if there's someone who kind of calls a lot because of side effects, or they're nervous about them, or they're on medications that could have potential interactions, then you could see them in 2 weeks. So I would say 2 to 4. Key questions. So I check in, I say, you know, first I check in about mood, and I say, how's your mood been? Have you been feeling any different since we started the medication? And what I do is I look back in my previous note and I look at what were their major complaints last time. So I'll ask them specifically, because if I say, how are you feeling? I get a whole range of answers. But if I say, last time you were complaining about feeling tired and unmotivated, how are those? And so I'll ask specific questions about their goals for treatment and what their major complaints were. And then I'll ask about, how would you describe your mood? And then I will say, are you having any side effects or problems with the medication? And then in terms of specific questions, you know, for example, you know, if there's somebody under the age of 24, I will always ask any suicidal thoughts about death or dying. Have you had trouble, have you felt kind of revved up on it, giddy, trouble sleeping? You know, that might be useful to ask everybody. That could be a clue to bipolar. So those might be more of the key ones. Those are more safety related, but you want to also ask about interactions. So symptoms related to interactions. So for example, if they were taking amitriptyline for sleep and you added Prozac, you know, that could increase the concentration of amitriptyline. You want to ask about any dizziness, confusion, feeling very sleepy. So you might just want to ask some specific questions around that. So if you know a little bit about the medication, you can ask specifically about those. I also, and I'm sure you do this, but each visit check weight and check blood pressure. Because if you're starting Effexor or Cymbalta, you want to check how their blood pressure is. And about weight, I ask, any weight gain? You know, people say, oh, I don't know. So then I say, are your clothes fitting differently? That's a way of asking, you know, weight gain. And I do track their weight. I make a list each date and I just type in their pounds so I can kind of compare, because people will gain weight on these medications.
Hi, Dr. Agarwal, Sue. So I'm hoping, can you hear me okay? All right. Good. So, you know, as we have been working in the Compass Care, or the Behavioral Medical Integration Collaborative Care Model, you know, a lot of research around, well, does keeping close contact, the monitoring in between, and then also monitoring the PHQ, do we find that we get folks to their depression management sooner than we would in the, you know, normal evidence-based care? And I don't know, thoughts on that?
Yeah, we absolutely do. I mean, I think that's primarily why collaborative care works, because we have more patient contacts than we would if they were following up every 3 months, you know, traditionally in a busy primary care clinic. So it's the contacts with the patient, and then I think it's the quantitative measure of depression rather than just qualitative. With the PHQ-9, we've got numbers which we can follow. This is the closest thing we have to an A1C or blood pressure. And that holds all of us accountable. You know, if the patient isn't following up with therapy, they're not doing their exercise plan, they're not doing their behavioral activation, you can show when you dropped off, you can see your PHQ-9 went down. It's accountability for us. Are we adjusting the medication quickly enough. We can look at that and maybe be more assertive about treatment. So I definitely think seeing patients more, talking to them more, educating them more about side effects, what medication they're on, encouraging them to stay on it. All of these factors, I believe, do get people to remission more effectively, and in some studies show 50% faster, than traditional practice.
And then the other, question is, as we think about our patients, some say, I don't want to take medications. I'd much rather use counseling or other services. And, how do you respond to patients around that and give them some leeway on choice?
Absolutely. Yep. Ultimately, it is our patient's choice, and often they feel a lack of a sense of control. And so we always want to be putting that control back in their hands. And, for some people, it depends. If they have kind of like a mild, moderate depression, no suicidal thoughts, no past hospitalizations, they're not self-harming, they have no substance use, they have kind of like a dysthymic depression, and they're in therapy and they're exercising, I might say, there aren't any real safety issues at this point. I might reflect to them, you did have a major depressive episode in your 20s. That increases the risk of another one happening. So treatment would be more preventive at this point. It can also treat what's going on now. I would also look at their history and say, you haven't done that well off medications. Looks like you were off medications for 5 years, and in that 5 years, things didn't go well for you, brought you back into treatment, or when you were off medications, it landed you in the hospital. So I just kind of look at what their history is and what the consequences have been. Or I say, you've been doing the meditation class, you've been doing the therapy for 6 months pretty consistently, but looking at your PHQ-9, your depression has gotten worse and worse. And so it looks like, would you be, it could, it's a good time to think about an additional intervention at this point. And to say, wouldn't have to be forever, and it would be something to help you get out of this, take the edge off of this depression so that you can have your therapy and natural treatments take you the rest of the way. I don't think the depression is going to be, the solution, and, certainly not something that we want to replace all these healthy lifestyle choices that you've made, but it's something to boost those effects. And we can think about 6 months to a year, and then, continuing on with the lifestyle changes. But I never force anybody. Now, if they're coming suicidal, I'm going to be more assertive about it and say, your risk of death is high right now. You have major depression, you're having suicidal thoughts. It's good you're in therapy, but medications can greatly increase the chances that you're going to be alive, that are going to help resolve this depression. And then I also will say, you're very depressed right now, and the depressed mind, you don't really want to make huge decisions when your mind is so depressed. When you're thinking about suicide, I can tell you're feeling kind of desperate because you're thinking that way. You want to make sure that you're making more conservative decisions right now, maybe opting into treatment rather than out of treatment, at least for now. And when you're feeling better, we can, of course, reassess the entire way. If you don't like the medication, we can stop at any time. I'm here. We can check in every 2 to 4 weeks if you feel comfortable with that. And I kind of just talk to them about what the options are. Usually, people ask for a prescription before they leave my office. I have very rarely had somebody who didn't want a medication. Now, of course, this is a self-selected group of people who are coming to psychiatry, but a lot of them come and say, I hope you're not a pill pusher. I'm not here for medications. I just wanted an evaluation. I don't like the idea of being on medication. So I say, there's no requirement. Let's treat this as an informational session. And I'm here to answer your questions and just let you know about what the treatment options are. And we can kind of go from there. And then people feel like some of the pressure is off. Okay, I have noticed after patients have had an inpatient psych stay, they can be really difficult to pull information from. It's important to get the info because we don't always have the notes. Any motivational interviewing tips would help. This is the demographic I find to be the most difficult to open up. Yeah, so that discharge summary is really huge. I would say trying to get that at all costs, because it's really hard to treat somebody after a hospital stay. You know, something big happened. They're not always the best historians, or they may not want to share with you what happened, or they may disagree with the diagnosis and so give you a different diagnosis or just omit that diagnosis. So, you know, I think I think part of motivational interviewing for them, one thing is to say, well, you're here in my office today. What brings you here? What was it that made you come seeking help today? And so just highlighting for them what they actually are doing, because that's they're contradicting themselves by not opening up, but then also showing up for help. You know, so part of it is acknowledging that they've been through something very traumatic. This whole process could be very scary, especially if it's your first hospital stay. People think they're now crazy. They never thought they'd be in the hospital. They were there with a lot of sick people. They're on new, potentially potent medications. So I think a lot of education and just talking to them about, you know, it kind of depends on what they're not opening up about. If they're not wanting to share their diagnosis or why they went into the hospital, you know, I let them know, you're here for help. My ability to help you is limited if I don't have the information. So there's only so much that I can do for you if I don't really know what's going on. And sometimes people don't open up about trauma. And so I say, if it's something that's, you know, scary or traumatic for you, we don't have to go into details. But if you could just give me some bullet points, like what, you know, the short version in a word or two or sentence or two, what brought you into the hospital, that could be helpful. And I'm here to help you and here to help you reach your goals. So that is a way for me to help you reach your goal. And so kind of working from that angle to let them know you don't have a certain agenda other than a shared goal of them getting better, but you need information to help them get better. And I would give them the specific information that you need. So, for example, why they went into the hospital, you could say, it's important for me to know why you went there, so I know what symptoms to be looking out for, so I can be checking in, on your progress. It will help us decide what medications could be most helpful for you, and how do we prevent that from happening again. So I also might validate, you've been through a lot. I completely understand. You don't want to relive it. Why would you want to go through that again? But maybe if there's some ways, certain parts of it that you don't have some trouble talking about, we could start with those. So, this will be non-optimal. You're not going to have the information you need. And this visit may be building rapport, trust and rapport, because something must have happened that they have closed up about. And so that's really going to be your goal at that visit. The parts of motivational interviewing really are going to be validating for them what's happened, highlighting for them what they are doing that shows motivation to get better. They showed up, they scheduled with a therapist, they're taking the medications, and I think reflecting for them also, what makes it hard for you to, what was your experience like, them, and then kind of reflecting for them what you're noticing about how the experience was. You might get a lot more information that way.
Another question I have, Dr. Agarwal, is the need for relentless treat to target and treatment intensification. It's similar to our other chronic conditions. Sometimes we don't always think about the behavioral health conditions in the same way. We wouldn't be happy with a diabetic patient coming in with a A1C of 15 and saying, well, gosh, have you been taking your insulin? And from there, just drop it for several months. So your thoughts on that?
Yeah, good question. It's important to treat depression to remission. That is always our treatment goal. It's never just response. Response is a 50% increase, which is great, unless that 50% increase got them to remission, which is no symptoms or PHQ-9 of 4 or less. The reason for that is any residual depression can precipitate a major depressive episode. So it's kind of like with antibiotics. If you partially treat, it can make it worse. So if we're sort of partially treating depression, there's always some depression hanging around. That depression becomes much harder to treat and increases risk for more severe depression. So we want to treat to remission, even if they're like, I feel great, I'm active, I'm just having some trouble sleeping, and sometimes I don't feel motivated to do things, but I feel pretty good, but their PHQ-9 is like 7 or 8. We want to push it. We really want to push it to get to 4 or less. That little bit is important. Now, looking at just the number of the PHQ-9, we have to be careful. You want to look at questions 1 and 2 especially, because those are the specific major depressive questions. Ability to enjoy things, look forward to things, and what their mood is like. Depressed, mood, sad, down, depressed, hopeless, worthless. If those are both 0, and their complaints are, they're saying, I feel wonderful, I'm having some trouble sleeping at night, and that's my big concern, or my appetite, I'm just eating a lot more, and that's what, they're eating more and they're not sleeping well, that may or may not be related specifically to the depression. And so, what we want to do is target those symptomatic complaints. Do we need to adjust their sleeping medication? Is there a binge eating disorder that we've missed, or is maybe the Seroquel that we started or the Zyprexa we started increasing their appetite? Do we need to adjust that dose to reduce how much reduce their hunger? And we may not necessarily adjust the antidepressant, but we want to get it to where questions 1 and 2 are 0, and ideally the entire PHQ-9 is less than 4.
Right. Well, I'm not seeing any other questions, so we'll just do a quick shout out if anyone has additional questions. Give you a minute. In the interim, Dr. Agarwal, I really would like to thank you. You just have such a wonderful way of sharing with us the behavioral medical integration component and how we can build that into our care management work, and just really good practical advice. So thank you so much. Really enjoyed your presentation, and certainly enjoy your approach and great information.
Wonderful, thank you. And thank you for all the participation and great questions. I really appreciate that, and it's very enjoyable for me to do this, so thank you.
Yeah, so just wanted to let folks know, we're always open to suggestions. So if there are other topics that you would like to have us cover on this call, anything related to behavioral medical integration, I know many of you are working on that related to some of the CPC Plus requirements. So we're happy to help where we can. Just let us know what those topics are. We will be talking about a little bit switch substance use next month, and we have an individual who will really be talking about the conversations with folks that are on medications that we're concerned with, in particular the opioids, and talking about tapering. So crucial conversations and how we can broach the subject of tapering. So just a plug there. Other than that, that really ends our session for today, and hope many of you will join us again. And thank you again, Dr. Agarwal. So thank you, and with that, we'll sign off. So thanks much.
Thank you. Bye, everybody.
Bye-bye.